I'm welcoming everyone to Health Equity in the EU seminar, sponsored by and supported by EASE and the DEI committee that I am a part of, as well as two of my my co-authors who are helping with this webinar today. I'm joined by Sidra Khan-Gökkaya. Sorry, Sidra, if I am messing up your last name. She's a health equity researcher and an anti racism officer at the University Medical Center Hamburg, Eppendorf. And we've had the privilege of working together for almost a year now. I'm also joined by Sylvia Maina. She's the medical communications editorial manager at Edita Med, and we are both members of the EASE DEI committee, along with Diana Samuel, who is the acting editor in chief at Lancet Digital Health. So, thank you everyone for joining us today. Please put any questions that you may have in the chat. Our indispensable help. We can't get along without Mary Hodgson is helping to, along with Diana Samuel, is helping to um, get your questions answered and get them listed so that we can have a discussion at the end of the webinar. So, without further ado, I will just introduce our first speaker, Sidra Khan-Gökkaya, who will introduce the purpose of why we are even holding this webinar. A very important purpose to bring attention to the need for um, more interventions and initiatives to tackle health inequities. So, what Sidra will go ahead and explain is the rationale for our scoping review, which is this type of study that we did to try to collect information on initiatives and interventions being performed currently across the EU. And my colleague Sylvia will explain the preliminary results that we found. And right in the middle, I'll give a brief talk about some current inequities, as well as a brief discussion of some results as well. Thank you, everyone. Sidra?
Thank you so much, Shelly. So as we all know, health equity is widely acknowledged as a central goal for health systems, public health policy, and also health research. I think we probably all know that the World Health Organization defines it as a situation in which all people have the real opportunity to achieve their full potential for health and well-being, regardless of their social, economic, demographic, or geographic background. And this definition for our purpose is particularly helpful because it goes beyond simply describing differences in health. It asks whether those differences are fair, avoidable, and shaped by different unequal conditions. And for a long time, discussions on health equity have been closely linked to social determinants of health. These include factors such as income, education, employment, housing, and access to healthcare services. And these determinants strongly influence who is more likely to become ill, who has access to prevention and treatment, and who is able to recover and live well and healthy. At the same time, the debate has expanded further in recent years. So, increasingly, scholars and practitioners argue that we also need to pay closer attention to the political determinants of health. This means not looking only at social conditions, but also at the political decisions, the power structures, the institutional priorities, and the governance mechanisms that shape those conditions. So, if we want to understand health inequities, we also have to ask who has power, whose needs are prioritized, what policies are implemented, and which groups remain overlooked. And in many ways, the COVID-19 pandemic made the relevance of health equity quite impossible to ignore. It acted almost like a magnifying glass, It did not create health inequities from scratch, but it made existing inequities so much more visible. We saw that infection risk, working exposure, access to care, even mortality rates were distributed very unevenly. People in precarious jobs, crowded housing, racialized groups, and other structurally disadvantaged populations were more heavily affected. And although health equity is increasingly used as an important concept in public health, there is still surprisingly limited information about specific health equity initiatives in Europe, particularly those that address the needs and realities of marginalized populations. And this is important because health equity is closely linked to broader questions of health and social justice. And from a more critical perspective, health equity should not only be understood as a neutral or descriptive concept. Rather, it explicitly concerns disparities that arise from power relations and categories of difference. These may include racialization, class, gender, disability, language, or the legal status. So these inequities do not emerge randomly. They are often produced and reproduced through systems of exclusion, through unequal recognition, and institutional procedures that privilege some group while disadvantaging others. Another major challenge here is the limited operationalization of intersectionality within health equity. So we often acknowledge that people do not experience inequity within or through one single category alone, but through the interaction of multiple social positions. Yet in practice, this insight is still very difficult to translate into research designs, policies, and interventions. So a lot of approaches remain organized around one single category, which may not represent the reality of the populations we are talking about. Another related issue is that discussions on health equity are often still fragmented across sectors. So, health equity may be discussed in public health or in social sciences, but not necessarily in a joined way. And this can make it harder to build coherent institutional strategies. So to sum this up, even though the term health equity is widely used, we still know too little about what is actually happening in practice, especially for groups who are structurally marginalized. So we as a group wanted to take a step back and ask some fundamental questions. Our first research question was, how is health equity defined and conceptualized in European studies and policy documents? And this question was important because we cannot assume that health equity means the same thing across all settings. Our goal was to understand not only whether health equity is mentioned, but how it is actually interpreted and framed. And then the second question was, what kind of health equity interventions have been implemented in Europe? Here we were interested in moving beyond the conceptual level and looking at practice. We wanted to identify whether there are specific initiatives, interventions, programs, policies that explicitly aim to promote health equity. And the third question then went further into the characteristics of these initiatives and interventions. So, what populations are being targeted, which methods are used, what outcomes are reported, and what determinants are being addressed. And these questions allowed us to unpack the field in more detail. And our aim was to not only to map the presence of health equity language in those studies, but to really understand the substance behind it. And yeah, with that, I would like to turn to Shelly to give us an overview of modern types of inequities that were a major point of relevance for our study.
Thank you, Sidra. Sidra set up the rest of the presentation beautifully to really break down the fact that health inequities can be all forms, whether we're talking about people with neurodivergence, cognitive abilities that prevent them from entering the workforce or affect their quality of life, as along with other inequities. So we were really looking at a broad band of whatever was mentioned in the health literature, and we didn't focus on any particular inequity. And we'll see that later when we describe our preliminary results. So I just like to turn attention to a modern inequity in the mid 20th century. A psychiatrist named Frantz Fanon noticed in his work with migrant workers that they displayed their pain manifested due to psychological distress that they felt in their daily lives, due to working conditions, due to living conditions that were probably less than optimal. And as a psychiatrist, he coined this phenomenon, this manifestation as of pain in migrants as the North African syndrome. But physicians other than himself at the time were influenced by institutional racist practices due to people being put into racialized categories, and medicine was practiced where differential treatment was offered to racialized groups. The physicians distrusted complaints of pain from migrant patients from these North African backgrounds and diminished any feelings of pain and discomfort that they were experiencing. And I made a reference to the French study that describes more about Dr. Fanon's work. Dr. Fanon extensively published research works on the North African syndrome, and you can find the reference on the bottom of this slide. Next slide, please, Sidra. Thank you. So, as a syndrome described back in 1952 by Dr. Fanon, this syndrome has been rebranded as a label, a stereotypical label, to diminish or kind of anecdotally referred to pain experienced from people originating from Northern African or sub-African countries, sub-Saharan African countries, and even people from the Mediterranean region, such as Turkey. And this pervasive use of the Mediterranean syndrome or morbus mediterraneus is in current use in the French and German medical systems and in their medical educational systems. So from empirical research, I've noted three empirical research articles below the use of these stereotypical terms to diminish pain experienced from people of North African or Sub-Saharan African heritage is being taught to medical students, and is pervasive in medical practice today. And we can only imagine that the harmful consequences that could that are consequent due to these communities, these populations' pain being ignored or diminished. So the North African syndrome was coined by Professor Fanon, but the Mediterranean syndrome, as a stereotypical name to diminish pain in people from those populations that I previously described, is actually a real disease. Mediterranean syndrome has its own international disease code. It's also medically known as the familial Mediterranean fever. but physicians starting from mid 20th century and to today are still using a stereotypical label to belittle pain and distress from these populations. So we can see that this differential treatment of patients from these backgrounds could result in differential care, in worsening of chronic diseases, and have potential very serious adverse effects on their health and mental health. So, given the dearth of studies that have really looked at what interventions are being conducted, what different types of research studies are being conducted to describe how are inequities such as this being tackled, how are researchers conducting empirical research to try to reverse these inequities that we see. Are there educational interventions being performed? Are there community-based educational workshops, any type of intervention we could find, we set out to look for in a systematic way. So the next slide describe, thank you, Sidra, describe how we designed our scoping review to even start to look for what is out there as far as initiatives to help start to tackle these real world inequities. So back in January, we did a search of the biomedical literature using bibliographic databases that offer comprehensive information about research studies, particularly biomedical research studies. And we chose the time frame 2010 to 2025 to really capture any policy changes. As Sidra mentioned, especially due to COVID-19, we saw we saw such a need for um, policy change towards health equity and having everyone have access to health. So this period captured a lot of changes across Europe as far as DEI is concerned. And I also provided, and you'll see in, sorry, Sidra, you'll see in the right hand bottom corner of some of the slides, the QR code for our protocol, which is registered on Open Science Forum. So I'm giving a very brief overview of our very detailed methodology, which you will find in our protocol. Thank you, Sidra. So as I mentioned before, we are still conducting our review of articles to include in our final scoping review. What I am reporting today and what Sylvia will report on later after I will report these preliminary results is just what we have managed to do so far. So, from our search of the electronic databases, we retrieved almost 600 articles and we excluded many articles for different reasons not being applicable to any of the EU 27 countries that we chose to focus on, or the articles were review articles that didn't describe individual country based studies or community based studies like we would like. So we excluded any inapplicable studies, and in the end, we have 27 studies that we will talk about today. Thank you, Sidra. Okay, so here's a little bit more on what we included. I mentioned that we focused on EU 27 countries, and we did not focus on any single type of health inequity. We generally search for inequities and whatever the investigators described as far as what they created initiatives for, what they conducted studies to try to understand. We included those studies as long as they were detailed enough and provided enough data for us to analyze. Any articles that were published before 2010, we did not include. Thank you. So, as far as what data we used, we extracted authors' names, study design, target population, the country that the initiative or the intervention took place, and health equity guideline use, disease studied, outcome and results data, such as participant number of participants. And we followed standardized guidelines to report our scoping review so that what we report is transparent and can be reproducible. We follow Joanna Briggs Institute guidelines for conducting scoping reviews. We use Prisma Equity Guidelines, which is a guideline created by the editors and researchers and all of the people who help researchers report data better. And we use these guidelines to report our equity review through an equity lens, as well as other methods to report the data narratively if we could not do that so quantitatively. And any frequencies and percentages were reported for the study characteristics. Sorry. And again, I put the QR code in the lower right hand corner for you to scan and look at all of these details that I'm not mentioning. And I have references to our guidelines that we use on the bottom of the slides. So now it looks like the next slide is we're going to start to talk about our preliminary results. We still have many studies to go through, but we wanted to share these preliminary results with you. So most studies were published in 2025, and it's very interesting because it really it kind of speaks to the fact that maybe the COVID-19 pandemic kind of gave people a spark to really start to look at health equity in a different way due to the disparities and the inequities that we've seen due to the pandemic. So it's interesting to see that increase. Thank you. Thank you, Sidra. Okay. So many studies had results
Mhm.
applicable to multiple EU countries, but um, many studies were conducted in the Netherlands across these different countries, France, Germany, Italy, and Slovenia, and so forth. And different policies as I mentioned before, due to the COVID-19 pandemic, have been initiated in countries like the Netherlands, where you saw policy changes, and that study is noted in our protocol that you can find online. That the Dutch government really changed and revamped their health equity policies in light of what was going on with COVID-19. Next slide. Thank you. So we also uh, extracted the outcome type that we observed from the 27 studies in our preliminary results. And most of the outcomes tackled or tried to address systemic or cultural change to enable access to healthcare for marginalized populations, for underserved populations, and for people in the community who were otherwise socioeconomically disadvantaged. Followed by building patient self-sufficiency and empowerment. Several of our studies had co-design designs. They actually involved patient partners in the study design and in properly and relevantly reporting the results of the study, which was really great to see. And we have noted that as well in our data collection. Next slide. So many of the studies didn't specify a specific disease, and we did not set out to search for health equity studies that tackled certain diseases or disorders or health problems. So we saw in our results that most studies, they really just wanted to, in general, address health inequities throughout the life course, whether they were looking at parent-child relationships to try to increase that bond that they thought would help children through their life course and lead healthier lives, or other general health inequities. Next, we saw health literacy and health promotion, where investigators really worked with communities that had notable lower levels of health literacy to try to boost health literacy, to try to incorporate them more into health systems and be more active consumers and take charge of and understand how the health system was affecting them and barriers that they could address as well them as for themselves. And we saw obesity, diet, and physical activity, and we saw multiple studies that used mobile applications targeting socioeconomically people of low socioeconomic status to try to increase their interaction with mobile applications. More digital health applications are being developed. And because of the digital divide, because of low digital health literacy in certain populations, these investigators set out to introduce a type of and develop a type of mobile application to increase physical activity and increase better dietary habits in these populations. So those are some examples of what we saw, and there are other diseases that were studied. And investigators created initiatives for, such as climate change and mental illness. Next slide, please. So, most of the target populations, the relevant target populations that we saw were adults and older adults, older than age 65 years. But we also saw that a good number of studies targeted children and families because these investigators believed that the earlier children and families receive an intervention that is helpful, that is relevant, they believed that children throughout their life course could have improved health and be able to have decreased health disparities. And this is what their goals were in these studies. Next, please. So, um, in a health framework sense, in order to really describe and frame how what lens the researchers took to describe the characteristics of their participants, the other factors that could affect how participants interact with the health system, interact with their healthcare providers, or even care for their own diseases. The different frameworks were used, and the most prevalent framework was the social determinants of health. And I noted which studies used those on the bottom of the slide, followed by other frameworks called the transcultural care and cultural competence and cultural safety, and also social cognitive theory. One study also used the Medical Research Council's research framework for complex interventions in healthcare. But I would just like to note that none of the studies used a health equity guideline, which is different from a framework. The health equity guideline, as I mentioned before, we use the Prisma Equity Guideline, which are guidelines created to help researchers view their study with a health equity lens, specifically health equity, to report relevant characteristics as well as systemic um, barriers, systemic or institutional barriers that could also be at interplay with how with the with the characteristics of the participants. So that is just I just wanted to make that clear. And the next slide will show when I talk about health equity guidelines. I just want to report that there are a good handful, if not more, of health equity reporting guidelines for researchers to use to view their studies with a health equity lens, to report relevant participant characteristics, um, and also not only that, but to use these tools to point out systemic, institutional, and other factors that are influencing how these individuals in your study, whatever their background is, how are institutional factors affecting their access to health and their ability to attain good health. So the Consort is an Equator created tool. The Equator Network also created the Prisma guidelines, and they're a group of professionals, editors, and clinicians that got together many years ago to create these guidelines to help everyone who is reporting about health, reporting about people, reporting about humans to make the reporting relevant. And I listed also our Prisma equity guidelines, but also the sex and gender equity in research guidelines is an important one and very relevant for the studies in our scoping reviews, the strengthening the reporting of observational studies equity guidelines. Many of these studies that we looked at were qualitative, with interviews or um, observational types of studies, and these guidelines could have been easily used to report more of the participant level characteristics in a relevant way. Thank you. So I hope I'm not going over time. Please, someone tell me if I'm taking too long. So we saw that from our co-design studies, we saw from those studies where participants and community members were really a part of the study, from the design to results interpretation to writing the discussion. We saw that feedback and interaction and involvement of participants really helps make changes. We saw results from several studies where um, in Sweden, parent child interactions were improved to help strengthen that the children's health just from a stronger parental bond. That resilience was really worked on to try to keep children healthy and hopefully healthy throughout adulthood. In undocumented migrants or immigrants, identified language barriers caused by that cause decreased access to healthcare in a study where they worked with the investigators to try to point out what barriers did they experience, and then change could be made. Targeted interventional um, these strategies can be identified through the study and actually changed in practice. And in another study, there was curriculum change in a nursing school in Spain, where after an educational intervention about caring for patients and increasing confidence of caring for patients from diverse ethnicities and cultures, the students' confidence increased. So they were more confident to care for um, people who were not culture belonging to cultures or ethnicities of their own. So we are seeing some really great results from these preliminary results that we've seen, and we would love to report more about these types of studies to you in another webinar in the future when we get when we do analyze more studies. And next, please.
Yeah, thank you so much, Shelly. So I would just like to kind of sum up the results and briefly reflect on some implications of our findings. So, one important takeaway is that health equity initiatives across the EU states do exist. The field is not empty, and there are clearly efforts underway to address inequities in different national and institutional contexts. And this is encouraging because it shows that health equity is not just like a theoretical concept, but is also beginning to take shape in practice. At the same time, our findings also suggest that more interventional designs are needed if we want to better understand what these initiatives are actually effective for and how they reduce inequities. A lot of initiatives are promising, but we still need stronger evidence on their impact. So, in other words, it is not enough to know that one initiative exists. We also need to know whether it changes access, outcomes, experiences, or other structural conditions in meaningful ways. A second implication concerns the nature of inequities themselves. Our review suggests that inequities linked to systemic barriers were more meaningfully addressed when decision makers and community members were involved in reviewing actual policies and structures. I think this is also something that Shelley mentioned and gave a really good example for. And it reminds us that health inequities are often not simply the result of individual disadvantage, but actually of institutional and organizational procedures, rules, and priority. So, one essential implication is that meaningful health equity work requires both engagement with communities and engagement with those who shape policy, institutions, and implementation. And there are also implications, of course, for journal editors, publishers, and peer reviewers, which is especially relevant for our setting today. Depending on the field, the involvement of participants and a broader range of stakeholders can make health equity initiatives more meaningful. And what was really important is that research on health equity should not only be assessed in terms of methodological rigor in a very narrow sense, but also in terms of engagement. Who was involved, whose perspectives shaped the research questions, how were community participants part of the study, what populations were made visible, which ones remained absent. These are all important questions to promote the field of health equity. And related to this is one very practical implication to encourage the use of health equity reporting guidelines. Some of them Shelley has already presented. And these guidelines can help improve transparency and ensure that the published research clearly reports on who is included, what inequities are being addressed, what contextual factors matter, and how relevance for marginalized groups is considered. And this can not only strengthen the quality of reporting, but also the usefulness of the research for policy and practice. So, yeah, overall, our findings suggest that health equity work in Europe is developing, but it still needs stronger evaluation, deeper attention to systemic barriers, and more consistent institutional and publication practices to fully realize its potential. And with that, I invite Shelley back for the outro. I forgot to.
Thank you, Sidra and Sylvia. I apologize that I did not let you do
Don't
your
worry,
part.
there's no problem at all. You presented perfectly the results, so no problem, absolutely.
Do you have anything to add about the results?
No, just I was curious to hear what people that have here in our webinar may think about these preliminary results, because as you said, there were only preliminary findings, but they can show a sort of trend. So maybe they have their perspective, reflections that they can share during the discussion after.
Thank you, Sylvia. Yep, that's a great point. So we are, as Sylvia mentioned, we still have these preliminary results, and we're working away at extracting more data. Um, so the previous slide showed the co-authors who are helping us. Some of them have moved on to other projects and other universities, but we are going to still gather a team. If any of you are interested in the audience to be a part of the team to help us extract data, please contact us. Here's our contact information. And please take a look at the protocol at your leisure for more detailed descriptions of our methodology and our design and our results. Thank you very much. And I would like to have a discussion. This is really an exciting field for me to work in health equity. I worked previously in health literacy, which is a kind of an umbrella. Health equity is an umbrella term for any type of research that helps people attain good health, and if some kind of structural barrier is keeping them from it. And I work with elementary school children, and I work with adults to try to make information more readable, more accessible. And I really feel that this working in health equity is just a natural I just was naturally inclined to work with Sidra, work with Sylvia, work with the DEI committee, because I really believe that everyone should attain good health, and should there exist barriers, we gotta try to address them and tackle them if possible. And I really enjoy this work, and I really would love to have a discussion with any one of our attendees who to find out what health equity research you do, whether it's health literacy, whether it's some type of intervention in medicine, or whatever field you're in. We want to stress that, as I said, I think in the beginning of the webinar, that equity can exist in any research study, whether you are an archaeologist, whether you're a social scientist, whether you study life sciences. You can always look at any research methodology, any study design with a health equity lens. As Sidra mentioned, who are you including? Are your findings going to be representative, and for whom? So how you report your study, from its design to the methods to the discussion, all of that, you can use a health equity lens. If your research involves people, then you can look at your study with a health equity lens. And I would love to speak with any of the attendees to just find out what you're doing, or maybe if you're too shy to speak live on camera, maybe drop it in the chat. What health equity research are you currently doing? Are you interested in doing any health equity research? And Sylvia also opened the discussion to our preliminary results. Do you have something to add, or would you like to comment on that? And Diana Samuel is our moderator for our Q&A. So thank you, Diana, for that. So we will check the chats to see if anyone dropped any information. Okay. So it looks like we have researchers. Did anyone say where they're watching from? It would be nice to know where you're watching from, to know the location from where you're
I think a
watching.
couple of people did add that information. Thank you so much, Shelley, and to Sidra and Sylvia for this excellent presentation. I think just while we're waiting, while people digest and reflect on everything that's being presented. I just, yeah, it was absolutely amazing. I did have I've got a couple of questions, but I think the first one I just wanted to ask, because you did mention obviously there are these various frameworks and reporting guidelines that have health equity at the core. I was just wondering, is that something you took note of during the analysis of the studies? So what proportion of papers that you analysed were actually using these reporting guidelines?
Thanks, Diana. Yep, it was one of the variables that we set out to extract, and none of them so far reported any of the health equity guidelines that I listed in that table on one of the results reporting slides. And it was surprising. I mean, they did use public health and social science frameworks, which we know of one well-known one, the social determinants of health, which is one of the gold standards in public health reporting, where we look at public health researchers will look at what factors besides the participants' characteristics, because we know that participants' characteristics is not a biological reason for assigning disease, but what they experience in their lives. What are their lived experiences? What are structural systemic exposures? And that's what these frameworks really encompass. And these health equity frameworks kind of take it a little step further. The, the frameworks really tell us, okay, what they what could have they been exposed to in their daily lives to determine how their health state is at this point in time. But the health equity guidelines take things further with saying, okay, well, we know that systemic barriers exist. We know that uh, that exists, and taking it a step further to say, well, these systemic barriers could have, over time, led to worsening disease, worsening chronic conditions, lack of access to physicians, to regular routine care. And in that way, the health equity guidelines kind of really bring attention to those systemic differences and really call it out and give it a name, where the social determinants of health and those frameworks just kind of say, okay, these lived experiences um, are what they went through, but then the health equity guidelines kind of focus in more and give it a name. Yep, it was racism. It was this labeling of or belittling a condition to just being a silly feeling, but not like a real medical complaint. So I think the development of the health equity um, guidelines, they're a really great thing. And there's a group over at Cochrane. There's a Cochrane Health Equity Group led by Vivian Welch. Vivian Welch has been doing health equity research for probably 30 years now, and she was instrumental in creating the Prisma equity guidelines, and I believe the Strobe equity guidelines. One of those, she's definitely had her hand into helping researchers really give a name to, yep, that was racism, or that was some type of structural policy that really kept people from attaining good health. And people kind of danced around it with the social determinants of health. People said maybe possibly because they, didn't have access to good transportation, this was what they were exposed to. But these health equity guidelines really clarified it, really gave it an explicit name. And I think that's a good thing, as long as we can still do that here in Europe and really give these systemic barriers a name and really call it out and say what it is. In the US, that's unfortunately not the case. Many people are being censored from being very articulate about these structural barriers that we know are racism, that we know are discrimination, that we know are these practices that have lingered from many years ago. So I just really think that um, we need to encourage more authors to use reporting guidelines. And Vivian Welch, the same researcher that I mentioned who was instrumental in creating health equity guidelines. She recently did a study that showed her and her colleagues. She was the head author, the senior author. There was another first author. I could provide the link for that article for all of our panelists. Maybe in an email after this, maybe a follow-up email, but they found that reporting guideline use in observational studies was really low. And these are the studies where you sit down with members of the community, where you have a chance for better conversations with qualitative studies, with these cohort studies where you follow participants over time. People were not using health equity reporting guidelines and missing the chance to really make the results relevant for other researchers who want to do similar research or to find out what are these barriers that I could look for when I contextualize my research, when I describe my research. I want to see if I see these same barriers and give it a name and be very articulate about it. So it's unfortunately we'll probably see with the remaining studies that we'll probably see that deficiency in reporting guidelines as she's found, and I'm sure we'll find as well.
Thanks so much, Shelley. Yeah, it's you covered quite a few really good points there in terms of not only validating individuals' experiences, but also prompting researchers to consider these aspects at the point of research conception. And also, I suppose it's also a method to help standardize some of these approaches, which then obviously makes doing these kinds of evaluations a bit more streamlined. You also touched on a really interesting point about obviously the differences between what we're experiencing here in Europe versus say in the US, and also particularly what Sidra mentioned about, which I wasn't familiar with, political determinants of health. So I was just curious, across our wonderful speakers, your thoughts on what the impact, for example, on of the political influences and changes within the US, what impact, with respect to DEI, what that could have in terms of developing and implementing these types of frameworks going forwards. Obviously the negative influence on research funding as well. I'm not sure how many of these studies that you guys reviewed so far, how many of them involve collaboration across different countries. So, for example, between the US and other countries. So, yeah, in general, what do you think will be the impact in terms of health equity research going forwards?
That's a very interesting question. Thank you. I think my honest answer would be that we may have to take a step back because once we started the study, we talked about our starting point for when do we include studies, and we thought that we should start in 2010 because in 2015, due to the increase of refugees coming to Europe, we thought there may be a spike in studies on health equity. But we could see that under the umbrella of health equity, a lot of interventions were not designed under the umbrella of health equity, but more on migrant health, refugee health, kind of social medicine. So we do see that there are so many interventions, but we still lack a common understanding that it all kind of like influences health equity. And uh, when we have look at one group, we also have to look at the other group, and maybe there are similarities, especially in Europe. And I think we are still in a very privileged position in Europe, but at the same time, we can see how social policies are being redacted, how fundings are cut, especially in healthcare. I can only speak for Germany, would love to know how it is in Italy and Croatia as well. Um, but I think in being strategic with health equity, it is so important to have evidence, to have the numbers, to have the data, but to also be very inclusive. Like there are studies that show that it matters who we address, how we address them, how we communicate about these things. And I think I would hope that our study is a first step to showing that, yeah, these things matter and are important. I don't know, Sylvia, if you have similar experiences in Italy.
Yes, absolutely. And there are many inequalities in the healthcare in Italy, also because there are a few funds for the healthcare system now. So I think that if we will have a look at the situation in next years, there will be worse than they are now. And I was also very surprised when we extracted the data that only one study, maybe there will be more when we will complete everything, but there was only one study conducted in Italy, which is strange because it's a really growing problem, also because we have many migrants people that of course are the most vulnerable in this area. So I think it's yes, it will be a problem in next years, certainly.
Thanks so much. I don't see any questions yet in the chat. So I was wondering maybe obviously I know you guys have a lot more, quite a bit more to do in terms of analysis. But I was just wondering if you could maybe touch on if you already have in mind a dissemination plan for the results, particularly because it is such a topic of strong public health interest.
Yeah, thanks, Diana. Yeah, well, the original idea for this scoping review was Sidra's. So Sidra and I met at the European Public Health Conference that was in 2025. Yeah. And Sidra contacted me because of her work as an anti-racism officer and health equity researcher about the idea to do a study where we wanted to see what's out there, what research is being conducted to address health inequities. So, as I do scoping review methodologies and systematic review methodologies in my regular research work, we work together to create the methods, and we just want to publish it. We're joint first authors. We'll talk about the dissemination plan probably in a public health journal or whatever our co-authors all agree to. But we do plan on publishing this work, definitely presenting it at conferences that can reach all relevant interest holders, community members that will benefit from hearing these results, empowering community members, as well as encouraging other investigators to start similar studies in different settings, encouraged by what they see going on, maybe getting, some just inspiration, so to speak, from seeing that, yeah, it's still active. People are still creating these initiatives, even though maybe the designs aren't so great, but then maybe I can hear about a maybe not so well designed cross sectional study and design it and make it more robust for my setting and kind of learn from what's already being done. So we plan on disseminating it as much as we can through conferences, through publications, to involve as many relevant interest holders as possible.
And I think one of the main advantages of our group is that we all come from not only from different countries, but also from different like study backgrounds. So I think the interdisciplinarity and interprofessionality is like quite symptomatic for health equity. So that's a really nice sign that a different like approach is possible in health equity, and different disciplines can come together and share the best of their disciplines.
Thanks.
Yeah.
I guess we're ready to wrap up.
Yep, it's really been exciting. I really had fun, and I just really enjoy connecting with, as Sidra said, interdisciplinary professionals, professionals from all backgrounds. We have a law, someone from Macedonia in law, from a faculty of law. We have other participants from other areas. I think I saw in the chat. So this has been a great opportunity. Thank you so much, everyone, for joining us. Thank you to our wonderful speakers, our wonderful moderators, Diana and Mary. Thank you so much for all of your for your attention, and hope to see you again when we unveil more results that hopefully you'll find informative and useful.
Thank you, Shelley. Have a great day,
Thank you. Thank
everyone.
you, Sidra. Thank you, Sylvia. Thank you,
Thank
Mary. Thank
you.
you, Diana.
Thank you,
Goodbye,
everyone.
everyone. Thank you. Bye.